Good morning everyone. So this is continuation of WBC disorders. In the last class we have started discussion about neoplastic disorders of WBC. There are three categories of neoplastic disorders: lymphoid neoplasms, myeloid neoplasms and histiocytes. Lymphoid neoplasms are group of disorders of T lymphocytes, B lymphocytes and NK cells. Okay, here the cells, the neoplastic cell, it resembles a lymphocyte. Okay, so the neoplastic proliferations where the neoplastic cell resembles lymphocytes, okay, show the features of lymphocytes, we have grouped them under lymphoid neoplasms. And in myeloid neoplasms, the problem is there in the hematopoietic stem cells. Okay, and the neoplastic cells, they show features of myeloid series of cells. All the neoplasms that are showing features of myeloid series of cells, we have grouped them under myeloid neoplasms. And histiocytosis is tumors of macrophages and dendritic cells. Okay, in the last class, if you remember, we have started discussing about myeloid neoplasms. There are three categories of myeloid neoplasms are there: acute myeloid leukemia, myeloproliferative disorders and myelodysplastic syndromes. Acute myeloid leukemia, the problem is there in the differentiation. In myeloproliferative disorders, the problem is differentiation, but it is skewed into one direction. Okay, along with skewed differentiation, there is increased proliferative drive. There is excessive production of the cells of that particular lineage. And the third category, myelodysplastic syndromes, here the problem is in maturation. Okay, in the last class, we have discussed about acute myeloid leukemia. So, what is the problem in differentiation? I hope you remember what is differentiation and what is maturation. So, differentiation is picking up the lineage into which the cell is destined to become, whether it is lymphoid lineage or myeloid lineage. Even in the myeloid lineage, whether RBCs, platelets or WBCs. Okay, that is what you picking up the lineage is what is called as differentiation. Okay, in today's class we are going to discuss about myeloproliferative disorders, which are characterized by a problem with skewed differentiation and increased proliferative drive. So, let us talk about this. For example, just take a scenario. If there is a hematopoietic precursor cell is there, myeloid precursor cell is there. At any instant, it has to produce certain number of RBCs, certain number of platelets and certain number of granulocytes and monocytes at any point of time. Say for example, it is supposed to produce at an instance 100 RBCs, 100 megakaryocytes or platelets or 100 granulocytes. Okay. In myeloproliferative disorders, what happens is this equal distribution into or this equal differentiation is disturbed. Okay, instead of producing all equal hundreds of all three types of cells, only one type of cell will be produced at the expense of other cells. Okay, so now what happens is this precursor cell, it will differentiate only either into granulocytes or only it will pick up and develop into erythrocytes, or it may pick up into platelets. Okay, this is what we call it as skewed differentiation. Okay, not only this skewed differentiation, but also once the lineage has been picked up, that lineage is provided with a growth advantage. Okay, there is increased proliferative drive. Only that particular set of cells will like florid development of that particular type of cells will be there at the expense of other cells. Okay, this is what happens in myeloproliferative disorders. There are four important myeloproliferative disorders are there. One is chronic myelogenous leukemia, briefly known as CML. Second one is polycythemia vera, called as PCV. Third one is essential thrombocytosis, ET, and primary myelofibrosis, that is MF. Okay, just try to remember these terms, right? When precursor cell, when it has picked up RBC lineage especially, the resultant disease is called as polycythemia vera. Okay, when you dig into polycythemia vera, several contradictory statements will come up, but for meanwhile, just for the being, remember RBCs are more produced, or RBCs are thought to be produced more in polycythemia vera, skewed differentiation. If platelets are produced in more amounts, that is platelet lineage is taken up here, then it is called as essential thrombocytosis. Okay, if granulocyte series is taken, then it becomes chronic myelogenous leukemia. Okay, remember when granulocyte lineage is picked up for proliferation, the skewed differentiation is towards granulocyte series, then it becomes chronic myelogenous leukemia. We are not going to talk about primary myelofibrosis. This is out of our scope for today's class. Okay, let us talk about chronic myelogenous leukemia for this class. Okay, so what do we know about chronic myelogenous leukemia? This is a myeloproliferative disorder which comes under myeloid neoplasms. So the problem is in progenitor cells, hematopoietic progenitor cells, isn't it? Okay, and they should resemble myeloid series of cells at their in their structure. This is what we know about chronic myelogenous leukemia till now. Okay, let us look into the details of CML. As we already discussed, this is a myeloproliferative disorder. So the cell of origin for CML is pluripotent hematopoietic stem cell. I want you to remember this particular point very keenly. Please do remember the cell of origin for chronic myelogenous leukemia is pluripotent hematopoietic stem cell. The pluripotent hematopoietic stem cell, if you remember, it is sitting on the top of the hierarchy. Do you remember the flowchart that we have seen in the last class? So from pluripotent hematopoietic stem cell comes multipotent hematopoietic stem cell, and that will divide into lymphoid progenitor cells and myeloid progenitor cells. Okay. So now if you see, CML is a result of abnormality in pluripotent hematopoietic stem cell, which is sitting on the top of the hierarchy. Okay, remember this point. We will be needing this point later in our discussion. Okay, right. So the most common age that is affected with CML is adults usually. Till 50 to 60 years of the age is the most common age where you see CML. Coming to the molecular pathogenesis, what is actually happening to this pluripotent hematopoietic stem cell? The characteristic molecular abnormality that happens in pluripotent hematopoietic stem cell is called as Philadelphia chromosome. Try to get familiar with this term, Philadelphia chromosome. So what is this Philadelphia chromosome? We all know there will be chromosomes that are present in the nucleus, right? So from chromosome 9 to chromosome 22, okay, there is a reciprocal translocation is there. That means a portion of chromosome 9 is translocated into a portion that is present on chromosome number 22. So this exchange is happening between chromosome 9 and chromosome 22. This process we call it as reciprocal translocation. As a result of this reciprocal translocation, a funny thing happens. Usually cell proliferation rate, usually it is kept under check, right? The cell cycle regulatory mechanisms, they will keep in check the cell proliferation rate. Tyrosine kinase is one element that is important for cell proliferation. Okay, if it is present in excess amount or if it is present in an active state, the cell it keeps on going proliferating. Okay, so the Philadelphia chromosome formation, this reciprocal translocation, what it does to the cell is it activates tyrosine kinase of that cell. Okay, so now this tyrosine kinase is activated in which cell? Pluripotent hematopoietic stem cell. So now that hematopoietic stem cell, it will start proliferating. Okay, and for some unknown reasons, it will pick up granulocytic as well as megakaryocytic series of cells. Okay, the skewed differentiation is towards granulocytic series as well as megakaryocytic series. So obviously, what is happening to the erythroid series here? It will come down. Okay, so On a whole, look at this picture. So there is a pluripotent hematopoietic stem cell, and inside that there is one molecular aberration that is happening. From chromosome 9 to 22, there is a reciprocal translocation, which is leading to excessive tyrosine kinase activation. Along with that, there is skewed differentiation towards granulocytes and megakaryocyte progenitor cells. Okay, this is the pathogenesis of chronic myelogenous leukemia. All right. So now this whole story, it is happening in bone marrow. So pluripotent hematopoietic stem cells are present in bone marrow, right? So what is the picture that you expect here? So there is an excessive proliferation rate. So bone marrow cellularity will be obviously increased. So it is hypercellular bone marrow. Okay. So myeloid series definitely is increased here, and megakaryocytes are obviously increased here. And what will happen to the erythroid series? Usually it is suppressed. Okay, normal to mild suppression will be there. And apart from this, there will be increased deposition of reticulin. Remember this point, there will be increased deposition of reticulin. Right? Okay. So whatever happens in the bone marrow, that will be reflected in peripheral smear. Right? So in the peripheral smear, what you see is, what will happen to the RBCs? There is mild suppression, so the patient will have anemia. Okay, and what is happening to the myeloid series? They are increasing in the bone marrow, so the same cells will be split. They will spill into peripheral smear. So there will be high total leukocyte count. That we call it as leukocytosis. Okay, and the blast count will be, by definition, it is less than 10%. Remember, if it touches 20%, we call that as acute leukemia, not chronic leukemia. Okay, so in CML there is blast count will be increased, but it will be less than 10%. That is a rule. Okay, and platelet counts are usually elevated because it has chosen granulocytic series as well as megakaryocytic series. So platelets also will be increased. This is what you see in blood. So in the natural history of CML, after the development of this Philadelphia chromosome and this molecular abnormality, the patient may remain silent for about 3 years. Okay, after 3 years, in around 50% of the people, they will land up in a phase called as accelerated phase. Okay, so here what will happen is, there will be increased anemia and there will be thrombocytopenia. Okay, this is what we call it as accelerated phase. Next, the phase that comes is blast crisis. Okay, here there will be increased number of blasts will be there. Okay, usually in CML the amount of blast that we expect is less than 10%, but it will now become more than 10%, and it will reach to meet the criteria of acute leukemia. Okay, and remember the molecular abnormality that is happening is there in the pluripotent hematopoietic stem cell. Okay, which has got the potential to develop into lymphoid as well as myeloid precursor cells, isn't it? So in 70% of the cases in the blast crisis, 70% of the times you see myeloid blasts, but in the rare 30% of the cases you can even find lymphoid blasts, lymphoblasts. Okay, then we call that as lymphoid blast crisis. Okay, right. So that's why I wanted you to remember this pluripotent hematopoietic stem cell concept. It has got the potential to develop into both myeloid as well as lymphoid precursor cells. Okay, only in 30% of the people it might take up the lymphoid lineage also. Okay, then we call it as lymphoid blast crisis. Clinically, the patient, obviously due to anemia, he will have fatigue and weakness, and splenomegaly is the characteristic feature you will see, and there will be mild hepatomegaly and lymphadenopathy. Okay, this is the clinical picture with which chronic myelogenous leukemia patients will present to you. Okay, this is about CML. In the next class, we will talk about lymphoid neoplasms.